I think far larger studies have given quite a bit of credence to the idea that stress is an important risk factor for cardiovascular disease. In fact, I think it surprises many people to realize that those large studies have shown that stress has similar footing as the standard cardiovascular disease risk factors, that the attributable risk associated with stress is very similar to what you would see with dyslipidemia, hypertension, smoking, diabetes, for example, based on these large studies. This study of 293 individuals, while it gives some indications of the mechanistic links, is really standing on the basis established by those large trials, already making that risk clear. What's not clear, of course, is again the directionality of these interrelationships and whether or not one could truly modulate the downstream aspects of these interrelationships. That could be one of the ways to look at it. Certainly, if you're not able to modulate stress perception, maybe the next choice is to modulate the downstream biological consequences, the adverse consequences of heightened stress perception. If I had my druthers, I'd look for both being affected and intervened on. With the amygdala being part of the salience network, and although it is upregulated in response to stress, it of course is somewhat remote from the stressful insult in the first place. What we did look at is the relationship between amygdalar activity and common risk factors, and what we found was that age and a family history of heart disease were the best predictors of increased amygdalar activity. But at the same time, the downstream effects were quite independent of age and family history. After correction for those risk factors, and all the risk factors that we looked at for that matter, the relationship between amygdalar activity and CVD events was still robust. The amygdala exists as a key aspect of the salience network, and what it looks for are changes. And it becomes more active when there is a change that could relate to a threat. You could simply have a shadow pop up in the background and your amygdala could start to become active, and you can imagine that some people would have a larger response to that than others. Another way to activate the amygdala would be to flash faces, and that's actually one of the standard ways that people do in psychiatric studies to look at amygdalar reactivity, is they show a panel of standardized faces, and when there is a face that appears like it's responding to a threat, there is a heightened response of the amygdala to such a threatened looking face. Individuals with a lot of anxiety, individuals with PTSD and depression tend to have a heightened reactivity to such a panel of faces, for example. At the end of the day, the key aspect we're looking at are cardiovascular disease events. And anything that is going to increase the risk of cardiovascular disease is quite relevant to cardiologists. The way I would look at it is, if we were to walk down this path and identify interventions or treatments that would reduce cardiovascular risk associated with stress, then cardiologists would be in a position to really want to know a little more about stress in their patients' lives. For example, there are screening tools, simple questionnaires that we can give patients, and those questionnaires will give us a score, and you can imagine if a score were high, indicating that your patient had a lot of stress and that patient has cardiovascular disease, you might want to reach out for whatever effective interventions are developed down the line and offer that to your patient the same way you would offer lipid lowering treatment to your patients with atherosclerosis.